Okay, I think we're 5 after the hour. We can go ahead and get started, and I think some people will trickle in. Um, Welcome. Uh, Today we're going to be talking a little bit about ambient AI scribes in pediatrics. Uh, Here we go. I'm Lindsay Stevens. I am faculty at Stanford and the chair of our Pediatric Digital Health Task Force. And I'm joined by several of my colleagues from Stanford and other institutions. We've got Keith Morse, Aiden Zahedovash, Bethel Mieso, Chetan Sarabu, and Naimisha Chilakuri with us. And we're going to be having a great conversation. Uh, just housekeeping, none of us have business relationships with any ambient scribe companies, and wanted to tell you a little bit about where this all started. So we are a group of like-minded pediatric informaticists who have an interest in making sure that digital health tools are designed with children and families in mind. And we've led a couple workshops within the last year on pediatric AI and ambient scribes through the American Medical Informatics Association conferences, and brought together different experts to really talk about this and come up with some points for further development and use of this technology going forward. So we wanted to share that with all of you. Today, our main learning objectives, we're going to be working to appraise the implementation efforts of ambient listening in pediatric settings. We're going to talk about the evaluation of the unique pediatric-specific ethical, regulatory, clinical, technical, and implementation challenges with this technology, and identify some of the key considerations of using this in pediatric settings. So let's just quickly start with, let's hold on just a second. There we go. Start with some basics. So what is an ambient AI scribe? Many of those on the call have probably used them or are familiar with them, but really it's a tool that records the clinical encounter and uses artificial intelligence to generate clinical notes for healthcare providers. And you can see on the little screen here, the parent is having a conversation with the clinician and telling them about their daughter who's not feeling well, and it's recording the conversation, and then from that takes it and puts it and develops a structured clinical note for the use from the clinician and for clinical communication in the healthcare setting. So with that, I'm just going to go through a quick case so that you can be thinking about some of these aspects as we move through our conversation today with the panelists. Our panelists are going to kind of each talk about some different aspects and considerations for the use of ambient technology, and then we'll have some time for question and answers at the end of our session. So feel free to put anything in the Q&A session, and we'll be answering those a little bit later. So Dr. James is a pediatric gastroenterologist who wants help streamlining her documentation so that she can focus more on her patients. She's seeing Carlos, a 15-year-old male with possible IBD, in her clinic. He is accompanied by his mother, Brenda, who speaks Spanish as her primary language. In the clinic room, there's also an interpreter, Diego. The ambient AI scribe needs to digest the conversation between Dr. James, Carlos, Brenda, and Diego and create a coherent note. Since Carlos speaks English, he will respond to Dr. James directly. Anything that Brenda says will be interpreted by Diego, and he will relay the other conversation points back to Brenda. Since Carlos is a teenager, Dr. James excuses Brenda to talk to Carlos privately. Carlos mentions that he is in a same-sex relationship, but his mother does not know, and he wants to keep that confidential. So think about that a little bit as we're moving through our conversation today. I'm going to pass it off to Aiden to talk a little bit about the clinical impact of these tools.
Awesome. Thank you, Lindsay. So many of you will recognize this iconic drawing on the right side of the screen, which features a 7-year-old patient who drew the drawing in the middle. And as you can see, she's interacting with her family on the right side in the exam room. And where's the pediatrician? They're actually on the left and on this brown chair facing the other way, typing on her computer during the appointment. And if you look at the year from the drawing, 2011, this was just a couple of years after the HITECH Act. And this was when computers were playing a larger role in patient safety and clinical efficiency. And it really highlights, however, the hidden costs that computers have brought into the healthcare system with them. But it also does highlight what I think is one of the biggest promises of ambient AI and pediatric care, which is creating less moments like this and more face-to-face time with patients. This is especially important in the children's healthcare setting where taking the history is not solely the verbal content of the encounter, but also the observations and interactions that you have with the child and the family, which require both verbal and physical attention. I've been using Ambient AI scribes for the past year in my practice, and helping lead the rollout here at Stanford Children's. This has been a lot of the source of good feedback that we've had on people who are using ambient AI scribes in their practice is that it does give a lot more face time with patients and it reduces the amount of times that you would otherwise be diverting your attention to the computer. Um, speaking of communication, verbal communication is not always the most preferred way for all patients to retain information. And a lot of these vendors also produce after visit summaries or written patient summaries of the encounter that's tailored to the encounter itself. And, myself and others have used, tools like these to help personalize the deliverables for patients after the encounter that I think helps the patient provider relationship as well. On the next slide, we talk a little bit more about, yeah, awesome, thanks. We talk a little bit more about efficiency of care and how it impacts both primary care and subspecialty peds. Especially, starting on the left, especially with our primary care practices who see, large patient volumes and especially appointments, every 15 minutes, the documentation burden becomes a significant part of clinical practice. And that's where we see a lot of the usage and efficiency gains is in the high volume settings. The reports of numbers that you'll see throughout literature are about like 1 to 5 minutes of savings per note. And that's pretty consistent with what we've seen here as well. Um, there is like a hope of chart closure latency improving. So that's the time from when the clinician finishes seeing the patient to when the health system can bill the insurance company essentially. And the hope is that if you can complete notes faster, you can decrease that turnaround time. The evidence on that is kind of modest so far, and it's still kind of like something that all health systems are working on. Um, One more thing that is specific to pediatrics and clinical workflow and efficiency is sibling visits often, involve parents or caregivers wanting to talk about both siblings at once in the room. And then especially with ambient tools, when you have to switch the chart in order to ensure the information reaches the right chart, that does present kind of like a workflow barrier that we each have our own ways of working around that when we're using these ambient AI tools. And Chetan, I think we'll talk about that in a few minutes. On the right side, we talk a little bit about how the ambient AI scribes are differentially impacting both primary care and subspecialty ped settings. I think this is where we've seen a lot of the impacts of models that are trained on adult or general medicine being used in pediatrics and causing some of the inconsistencies that we've heard of. A lot of times you'll hear from docs that or other providers that specific parts of the encounter that they would have assumed would have been pulled into the note. Very specific details were not pulled into the note, maybe because the models aren't trained to think that that part's important. That's probably been like the most frequent bit of feedback that we've gotten. The other important part, especially in the primary care setting, well visit note templates represent like dozens of individual templates, and sometimes these templates vary across practices and providers. And a big part of incorporating ambient AI scribes into workflow is making sure the individual subsections from the ambient AI model are incorporated to each note. And that becomes a really labor intensive process of getting someone on board to start using these scribes, especially if they're not computer savvy in the first place to do that on their own. Um, and then lastly, we talked a little bit about patient-child dynamics in the room. As awesome as it is that you can pay a lot more attention to that when you're not diverting your attention to the computer, a lot of those things aren't documented, as you'd imagine, if they're not verbalized during the encounter by the AI scribe. And that is like an added step that a lot of us have had to remember to check for to make sure that any of the unsaid things in the room are written in the note.
All right. So next, we're going to talk a little bit about the considerations around applying existing regulatory frameworks to novel technology like ambient scribes. This is a single session, so we're not going to be able to go into the scope and complexity around many of these regulatory issues, but it's worthwhile thinking about how these issues get applied, and then the added burden or complexity that arise from pediatric modes of care. To illustrate this, what I'd like to do is focus on regulations around consent for recording, and focus on three specific areas. One is provide a little information around the variation in state recording laws, then provide some data around, for a given state, how is a single regulatory framework applied differently at different health institutions. And then finally, think about what are some additional considerations that the pediatric community has to grapple with beyond the existing regulatory challenges. So just to level set for everybody, as Lindsay mentioned, ambient scribes start with an audio recording of a clinic visit. People have a right to know when they are being recorded, particularly when they are speaking about personal health and wellness issues. These laws around consent for recording are familiar to many folks. It comes up in things like when you call customer service line and you hear a recording that says this call is being recorded for quality or training purposes, or when you walk into a store and you see a sign that says smile, you aren't a camera. All of those are in reaction to these existing regulatory requirements. Next slide, please. So the intent with this slide is to illustrate the variation among states for how consent must be obtained for recording conversations. The orange states here are one-party states, and what that means is that if a conversation is being recorded, it requires the knowledge and consent of only a single party in that conversation in order for it to be acceptable. For our ambient scribe use cases, presumably the provider's awareness and consent to the recording would be considered to be efficient or considered to be sufficient, and so there would not actually be a need to get additional consent from patients or anybody else in the room. Contrast that with the mint states, and those are all party states. So what that means is that all parties who are being recorded must consent to the recording. For ambient scribe, the implication there is not only in addition to the provider and the patient, but anybody else in the room, caregivers, drivers, babysitters, must also consent to a recording. Next slide, please. So if you think it's difficult across different states, even within a single state, there is substantial variability today in how these rules are put into practice. What we have here are some survey results that were collected last month from a group of 22 CMIOs from the state of California for how they are operationalizing these concerns around obtaining consent in their organizations. The focusing on the numbers here is probably not worth your effort, but thinking about the types of questions that still need to be fleshed out in order to make this operational is worthwhile. So the first is around how often does consent need to be obtained? Is it something that has to be obtained at every clinic visit? Or can you obtain it once from a patient and apply that consent to every subsequent visit? Thinking about how consent needs to be documented. Is it sufficient to have verbal consent from a patient that is then documented in a clinical note, or do patients have to sign something akin to surgical consents that they have been informed of the recordings? Finally, who is able to obtain the consent? Is it something that can happen at the front desk when a patient checks in, perhaps done by a medical assistant, or is it something that has to be done by the provider in the context when a recording is about to happen? Now, moving on to the third piece, where we start to think about what are additional complexities, additional considerations in the pediatric space. So the results that I presented here are from not necessarily pediatric specific organizations. So we see this variability in both adult and pediatrics. But what are additional things that we need to worry about with pediatrics? So the first thing is something that I hinted at earlier. So for places that are all party consent, you not only have to get consent from the patient and the caregiver, which is typically the sort of universe that we think about, but also everybody in the room. So if there are siblings, grandparents, friends who are in the room, they are all equally required to give consent. That is not only an additional burden in terms of time, getting everybody to sign a document or getting everybody to agree to the recording, but also our electronic health record systems are typically designed around the patient who is receiving care. So systems that require us to track documentation for people who aren't actually patients, like the grandmother of the child who is there for the visit, is immature and challenging for how we currently set up our documentation management. Second, we think about the differences between medical decision making and consent for recording. So pediatrics has a couple of unique environments in which consent or ability to give rights for medical decision making are not necessarily always just the patient or the parent. So thinking about foster parents who potentially may have rights for medical decision making, and then also thinking about teens who may not be considered emancipated adults, but in medical contexts are able to make medical decisions for themselves. The extent to which those medical decisions also apply to the ability to consent for recording on behalf of a minor is not totally clear. Finally, the question of age of consent. So we could all probably agree that a 2-year-old does not have to consent to have for recordings, and that a 16-year-old does have to have consent for recordings. But does a 7-year-old? Does a 6-year-old? These are all things that are, as of yet, not well defined. So take-home message here is that novel technology like ambient scribes brings regulatory burden. That regulatory burden is felt most acutely in the early phases of technology rollout like we are today, and that burden is felt more acutely in situations where there are unique dynamics like pediatrics. Thanks.
Wonderful. So, excuse me, I am going to move on to discuss the perspectives of this technology from our patients. And Lindsay, it looks like maybe these slides got mixed up because this is the end of my, if you go to the, sorry, no, if you go to the left, I think the prior slide, there we go. Perfect. So as AI scribes become more common in clinical settings, it's becoming increasingly important to understand how our patients feel about this novel technology, including their perceptions of the benefits of this tool, as well as the concerns around both their experience as well as how this tool is disclosed. And we heard a little bit about that from both Aiden and Keith earlier. I am leading the ongoing mixed methods study here at Stanford Children's to understand how our parents and adolescents perceive this new novel technology in pediatric care settings. We do have a secondary aim too of describing how these perceptions sort of compare across diverse populations, but I just wanted to share some of our preliminary results from the study here. So as you can see in this first graph here, many of our parents and adolescents generally feel comfortable, if not very comfortable, with the idea of AI scribes being used in their pediatric visits in the future. So these are parents and adolescents who had not had an AI scribe assisted visit. But for those who did have an AI scribe supported visit, many participants actually felt that the physician could focus more on them during their visit, which is a positive. And again, something Aiden alluded to earlier. And then many actually agreed too that they would like their physician to continue using this tool at future visits. And so these highlight the benefits and sort of the positives that we're seeing from our patients and parents around this technology. But I do want to kind of emphasize some of the themes that we've been finding in our qualitative analysis. So Lindsay, if you can go to the next slide. Part of this mixed method study involves interviews where we're actually talking with patients and parents who actually had an AI supported visit. And some of the emerging themes that we're seeing from this include themes right here that are listed on the slide. So disclosure, visit experience, privacy and security. And these three themes really continue to stand out as central to the patient voice. And so I want to just kind of focus on some of these here. Again, these are all very preliminary. This is just from 8 interviews, but do I think really highlight and capture some of those kind of unique experiences from our patients and parents. So Lindsay, if you go to the next slide, this first table is on disclosure. Overall, you can see that there's kind of a mixed grouping of perceptions around disclosure. And this is how the physician is disclosing the tool to the patients and family. And so again, this was something discussed in the prior presentation by Keith. But overall, you can see that one, the trust in the clinician actually contributes to a positive perspective on AI scribes. Two, there is an expectation that the clinicians should be the one to disclose, and this was sort of a neutral statement here. And then one of the negative statements that sort of came out of this is that there continues to be gaps in the understanding and communication about its use. And so even though we see generally patients feeling comfortable about this technology, when we sort of go deeper and in these interviews, we're actually seeing that there are lots of information about the AI scribes that patients and parents actually don't realize and sort of learn as a part of these interviews. And so I think that sort of highlights a little bit about the need for transparency and the need for kind of clearer disclosure around these tools. If you go to the next slide, Lindsay, I will share that overwhelmingly there's been positive feedback around the visit experience. So no negative experiences were reported from both patients and parents, which was excellent. Those who did have an AI-supported visit, again, had overwhelmingly positive comments. So things around kind of the optimism around the scribe being able to capture some of the comprehensive details of the visit gave patients and parents a sense of security. We did see that there wasn't much of a difference in at least this particular population of parents and patients in the clinician's focus on the patient and family. But primarily it was because these patients actually had a really strong positive relationship with their physicians prior to the Ambient AI scribe deployment. And so that was actually a positive that it didn't change much in their experience. But we do hope that it will improve the experience for those who don't have as good of a baseline experience with their providers. And then one neutral takeaway that I thought was very interesting was this need for, or preference, I guess, for a clearer visual separation between provider-generated text and AI-generated text, particularly in the AVS or the after-visit summaries and the clinical notes. And so that was something that a parent had mentioned to me and kind of wanted as a way to enhance transparency. And then I will just kind of end with the next slide, which is privacy and security. And I would say that this was overwhelmingly a topic that continued to I guess, shoot, I'm losing the word. I'm sorry. This was one of the topics that we discussed that overwhelmingly there were negative comments related to this. And I mean, you can probably guess that, but there were some neutral ones, right? So I think kind of as we think about the age of the patient, and this is where it gets, to be kind of more specific to the pediatric population, parents felt that, when patients were, or if their children were younger, they felt more comfortable and kind of thought about sort of the future perceptions around this tool as the child gets older. And so that's one of the neutral comments that I have here and highlighted. In terms of sort of the negative themes, there were a lot of concerns highlighted around the recording on personal devices, the retention of our personal data. And right now our retention is 90 days of both the audio recordings and the transcripts. And the discussion of sensitive topics as well. So particular teenager topics and confidentiality, kind of not only from the parent perspective, but from the teenager perspective too, was highlighted as sort of a thing that sort of they kind of had at the top of their mind. So I think this all kind of emphasizes the need for continued evaluation of our patients' and parents' perspectives on this technology, as well as co-development of patient materials to help improve and enhance transparency, especially and to supplement the disclosure around this tool as well. I'm going to pass it off to Chetan to further discuss some of the challenges of ambient AI use in pediatrics.
Thank you. Thank you so much, Bethel, and everyone. Really great to be here. My name is Chetan, part of Stanford, but primarily now based at Cornell in New York. And I've had the experience of using Ambient Scribe so far for approximately about 100 outpatient primary care pediatric visits. And I wanted to just start off this section of the discussion with a few personal anecdotes. One situation recently that I was thinking about, in pediatrics, as multiple speakers have pointed out, you have multiple people in the room, and even for something like consent, for getting consent, we talked about, Keith had mentioned, at what age do you ask the child for their consent? But another thing that I've noticed is that you often have multiple parents or guardians in the room, and they may have very different perspectives on how they feel about AI. So I've had a couple of situations recently where one parent had said, they were not okay with it, but then they looked to their spouse, and their spouse was like, I'm totally fine with it. And I didn't try to force or pressure their parent, but then, the parents took a little bit of time amongst themselves to decide how they felt about it. And I think, obviously in adult care, you also may have multiple caregivers in the room, but I think in pediatrics, that's even more prescient at times. So that's something to keep in mind. And then another situation I'll highlight as I get into some specific examples is I was taking care of a child shortly after Halloween, and they were describing all of the Halloween candy that they were having. And oftentimes in pediatric visits, we do like to connect the conversation back to the child's perspective and take a little bit more time to create that connection. And the ambient scribe in the note, it had actually captured every bit of Halloween candy that was talked about. But the way it framed it in the note, it described it in a way that I would not have done that. It said the child's diet consists of Tootsie Rolls and M&Ms and Twix. And it just, the framing and phrasing of it is not how we would have captured that. But I think with that, I want to take this moment to highlight a couple of areas where we think ambient scribes could do a better job for pediatrics. So wanted to highlight 4 specific examples, and then I'm going to go through each one of these with a mini clinical vignette and talk about why this really matters. So one, to the point I just made, when speaking directly to the child, to children, the language and context of what a child shares is not always properly contextualized. Many pediatric visits, such as birth or well-child visits, have a combination of structured templates plus free-form conversation, and scribes are not necessarily optimized for that. And it's a combination of what the scribe itself is doing, but also the integration with the EHR. Adolescent confidentiality needs to be built into the technology and the processes in place. And then it's also, as pointed out earlier by Aiden, it's fairly common for multiple siblings in one visit. And the way most scribes work right now is that they can only really focus on one patient at a time. So I want to talk about each of these with a few specific vignettes. Go to the next slide. So kind of zooming in further onto children's voices, it's really important that as as a pediatrician, our patient is a child, and at different developmental milestones, ages, they may be able to share more. And what I particularly focus on is to ensuring even a young child who may not be fully verbal yet or can only speak in broken sentences, I think it's really important to include them in the conversation of their care. And sometimes they're using broken words, languages, or combination of words and gestures. And with clinical scribes in this vignette, it's a situation where a 4-year-old is asked where it hurts, and they point to their ear and say it goes boom, boom. and the scribe doesn't necessarily pick up on that as a symptom, and the parent is maybe making some nonverbal comments, or maybe they say he seems fussy. But in my clinical interpretation of all that's going on in the room, I interpret that as ear pain and may note that down as such. And I think scribes have a powerful opportunity here to actually capture some more of that nuance that comes directly from a child's voice. But I think if we've only trained scribes to work off of adult data and they're not trained in some of the nuances of how children speak, they may flatten that language and not capture all of that nuance that exists, that richness that's there. Next slide. Many pediatric visits, a real common type of pediatric visit is the well child visit. And I believe Aiden had mentioned that we have dozens of templates at different ages. And the way most of these visits work is that we like to use a combination of the template plus free-form conversations. The templates have been highly optimized at different institutions to capture key structured data around sleep and food and a number of other facets of a child's life, such as developmental milestones. But oftentimes, we also like to delve into these further with open ended conversation. And so, in this vignette, at a 9-month check, the pediatrician's asking about motor milestones, talking to parents about sleep routines, providing anticipatory guidance on choking hazards. And the scribe captured a long paragraph about the sleep, but it might have missed those milestone responses and anticipatory guidance because it was really hyper focused on that sleep portion. So just a part of the challenge of making scribes work well for well child visits is that we have this combination of templated and freeform conversation. And this is really an open conversation and open challenge for not only scribe vendors, but really for health systems as we think about these mixed flows where we are using ambient tools with open conversation as well as structured templates. And in my own workflow, what I've been doing for well child visits is I will turn the ambient scribe on and I will use a structured well child visit template and go back and forth. And really, I'm using that templated note. But then any of the additional details the scribe captures, I will sometimes paste in to add more context and fuller bits of information. Next slide. As Bethel had pointed out, adolescent confidentiality is a really key area of focus that needs special protections. In most states, not to delve too far into this, but in most states, teens have the right to confidential care around sexual health, mental health, substance use, and this varies based on the age in each state, but generally when you're kind of in the 13 to 17 age range, and the way most health systems handle this is to create a separate, protected, confidential note. Oftentimes, there is information that may overlap or cross from a more confidential section to a non-confidential section. But when we think about this in the context of scribes, as Lindsay had described in the initial vignette, you have a situation where a teen is stepping out of the room, and there's all sorts of questions around whether you have to re-assent the child to keep the conversation going with the scribe or not. I personally have not had experiences in clinical care with using a scribe for an adolescent visit yet. But I think it's really critical to ensure that the adolescent themselves feels confident and comfortable with the scribe being used. And this is often a time where more sensitive information, such as the discussion of vaping or sexual orientation, may be discussed in ways that the parent may not be aware of that. And it's really important that scribes and the workflows around them are really designed to make sure that that is protected. Next slide. And the last issue that I'll highlight is the fact that a lot of pediatric visits have multiple siblings. And it really makes it's critical for parents where it's oftentimes hard to schedule time to have separate visits for each child. And part of the benefit of having multiple siblings together for something like a well child visit is there's often common social family history that we'd like to be able to take together, because children are in the same household and have some common genetic information. And unfortunately, the way scribes work, and generally EHRs, they're really set up for one patient at a time. And it does make sense because you don't want information about one patient to go to another patient's chart. But the natural workflow in a well child visit with multiple siblings is, while you do talk about each child separately, there is oftentimes information that comes up from one child to the other. And I've had this situation happen a few times where I have used an ambient scribe for multiple siblings, and we're talking about one child, and then all of a sudden a parent may say, oh, actually I forgot to mention something about the other child, and talks about that, and then the scribe is now mixing up information. It doesn't necessarily know the context of exactly who you're talking about, and this has the potential to create documentation errors that could be a safety issue. And so this is really a challenging call to not only scribe companies, but also EHR vendors and health systems, and how we can better support the technology working across multiple patients, multiple siblings in pediatric well child visits. So with that, I want to turn it over to Naimisha, who is going to really take all these challenges and talk about the opportunities and the wish lists of how we ensure ambient AI scribes really work well for pediatric care.
Awesome. Thank you so much, Chetan. I'm going to take us home with combining the incredible insights from my colleagues on the panel. For our 6 wish list items, I'm sure there's definitely more for what we hope ambient listening technology for pediatrics should try to optimize. So number 1, include capabilities to capture child input independent of parents, and specifically highlighting language concordant documentation. So being mindful of the fact that children and their caregivers may have different language needs that also evolve over time. Number 2, the ability to document both structured and unstructured free-form content to suit well child visits. I also want to expand that to include questionnaire data that parents might fill out ahead of the visit that often pediatricians are required to integrate into notes. And so including that information and being able to capture that would be really crucial. Number 3, capabilities for classifying information as confidential to only be placed in the confidential documentation. I know several EHR vendors are moving towards that kind of model for documentation, but not necessarily in collaboration with ambient documentation. So I think identifying that would be incredible. Capabilities for dual visit, number 4. So like Chetan beautifully exemplified, how do you capture ambient listening for both siblings or multiple siblings? Number 5, capabilities for multiple caregivers. So like highlighted, 2 caregivers may have different perspectives, and how do you document that efficiently? And 6, robust models that are trained on diverse pediatric populations, and number 2, pediatric subspecialty care whose ambient listening needs might be very different than that of a general pediatric visit. At this time, I'm going to turn it over to Lindsay to close us out.
Too many windows open. Okay, so here are some resources. We're going to have an opportunity. There's a few questions in the chat. If you have other questions, please throw them in. We're going to use the remainder of the time to kind of have more of an open discussion and want to hear what you are concerned about or have questions about or have thoughts on. These are some resources. The first one is our group's page. We're going to put a recording of this webinar on there in the near future. So if you want to share it with colleagues. The American Academy of Pediatrics, I know we have some representatives from that group as well, has a really wonderful AI education portal with lots of webinars on different AI topics. And then we also have representatives from the Digital Medicine Society here as well, and we helped co-create the Pediatric Digital Medicine Playbook, which isn't necessarily specific to ambient scribes, but talks about digital health in pediatric populations in general and is a really great resource. So I see there's a couple questions in the chat, and there's been a couple answered. So just we're not recommending any specific vendors here. We're really trying to think about this broadly. We do use DAX Copilot at Stanford. I don't know what they use at Cornell, Chethan.
It's also Dex.
Yeah, but there are many vendors, and this is really a vendor neutral presentation. The recording, as Aiden mentioned in his answer, the recording rules tend to vary institution based on the agreements made, but they are de-identified and then deleted at some point in the future. Some of those are very tight timelines. Some of those are up to a year, but usually after a year, those are purged. So, first question that is open. One person asked about the state of ambient listening AI scribes for inpatient settings. I don't know if one of you want to take that.
Yeah, so it's something that is coming. Vendors either have it available now or at a widespread availability, or it's in pilot use. We do not have it rolled out at our organization yet, so we have limited ability to comment on how effective it is, but it's coming.
Okay, and then let's see. Second one, let's see. Have scribes improved productivity? There was a New England Journal of Medicine article yesterday. Can you talk about note saving times at Stanford and Cornell? Aiden can speak to it a little bit here at Stanford.
Yeah, thank you for asking. I saw that article too this morning, and it was super interesting. It really depends on the provider and their workflows and what their baseline is and how long they're spending notes. On the practices where the scribe has been adopted most substantially here, we do see what is essentially kind of like an industry average of maybe 1 to 5 minutes per note that's been saved. But again, it really depends on like the clinical setting. And I think what this paper is showing too, that we see in other institutions see, is that it depends on how well it's integrated into the clinician's workflow and how much editing they have to do. A lot of our subspecialists, for example, have to do a lot of editing after the fact to make sure that the content from the conversation appears out into the note. So that's an example of where sometimes it does take a little bit longer to use the Ambient AI scribe to write notes. But it does depend on who is using it and kind of what clinical setting it is.
There's one that's kind of a tack onto that one. How has the adoption rate been amongst clinicians?
Yeah, Keith, you may know the exact adoption rates off the top of your head, but I think the kind of average between institutions that I've heard is between like 25 to 35% or so of all clinicians. And that's like a number that I've just heard throughout presentations. It's pretty consistent with what I've observed.
Yep.
I think one thing to add there too is it's always been a consideration is what should be the adoption rate. I think everyone assumes that should it be 100%, and I think just because the tool's available doesn't mean every clinician has to use it or wants to use it and is the most effective tool for their work. So I think just highlighting that, as I think adoption rates are good metrics to follow to understand how many clinicians are using, but not necessarily to say that 100% should be the target.
Yeah. Yeah, thanks. I'm sure over here we're looking carefully to see who could benefit from the most, right? Instead of ensuring that everyone uses it. Yeah.
Okay, we have one from Dr. Khan. How is the AI scribe described to patients for consent that have different medical literacy levels? Maybe Bethel, do you want to take that one?
Yeah, happy to take this. Hey, Amna. Thanks for the question. This is something that I think is still an ongoing discussion for several of the reasons that Keith brought up in his discussion around consenting. We are doing our best to actually work on developing patient-facing materials, excuse me, so that less of the onus is on the physician to go through all of the details that are important for improving transparency around this tool. So things around the data storage, the data usage, all of those things that we have information on, and the providers also do too, but don't necessarily have the time and the visits to kind of have that discussion, knowing that our visits are very short and limited. So I think it's really important. I think trying to figure out the best way to do this in practice has been the challenge. But I will say that with the materials we're working on, we're actually working directly with our health literacy team to ensure that, one, the patient materials are written in such a way that all patients and families will be able to understand those materials, as well as translating that into languages that our patients understand as well. And so we're being very mindful. I don't know how other institutions are doing that, but that's something of high priority for us here. And certainly things that we're thinking about as well. We've talked with, as we were deploying this, and I helped lead our deployment here as well. I had a conversation with our patient and family advisory council on what their thoughts were kind of initially as we were rolling this out, and that the theme around informed consent continued to come up. And so again, this is something that we're thinking a lot about, and we're wanting to understand how to operationalize it again in a way that kind of allows for clinical efficiency, but also enhanced transparency as best as we can, particularly for our marginalized patients and patients with low health literacy. So
do you want to briefly comment on Cornell?
Yeah, so I can just share, I think, in terms of institution-wide, we've sort of had a general consent language that was shared with everyone of how to ask for consent, and have not necessarily gone into specific language for different literacy levels. But I can share one of the things that I've been doing in all my visits is being very transparent with everything that's happening. So right now, I think what we do that's probably similar to most institutions is that the recording takes place on our phone using the mobile version of the EHR. So I go over to the family once they've as so usually I step into the room, I introduce the idea of using the AI recorder, ask if they are okay with it, and if they have questions. If they are, I then show them what it looks like, where I go over, log into their child's specific chart, show them that this is specifically within their child's record, and do a lot of visual pointing so you get oriented to it, and then show them the ambient record tab, and then show them right when I hit record as well. So I think that that visual showing exactly what's going on is helpful. It doesn't answer everything in terms of challenges with literacy, but I think being transparent is really key. And then I also, depending on the amount of time I have, I will try to show parents the draft note that gets generated, because it usually pops up a few seconds afterwards. And parents have found that really interesting, and some to really be able to see the power of using this.
Great. Well, I wanted to save this one because this is a question that tends to generate a lot of questions and swirl. But we have a question: what are your thoughts on allowing residents to use these tools? There's been a lot of concern about de-skilling, never skilling, unskilling that is weighed against the potential benefits in the productivity and patient-provider interactions. Bethel, do you want to start with that one?
Sure. Yeah. Hi, James. Thanks so much for the question. So yeah, we've had a lot of discussions around this, and I think everyone on this panel can share their thoughts. And I think it's been fascinating to hear the various program directors across our Stanford Medicine GME and their thoughts around whether or not trainees should be allowed to use this technology in training. And I will say, from analyzing their thoughts and feedback, it does seem like there is both overwhelming enthusiasm about exposing our trainees to this technology, as well as a lot of concerns around, just as you pointed out, the de-skilling that may come as a sort of consequence of using this tool. We at Stanford have actually collaborated with our GME representatives and leaders, and actually they decided to allow each program and program director to decide on how DAX was going to be used during their medical training. And we did see quite a wide range of variability across the decisions related to that. But I will say that there are some policies in place that are actually limiting the use of certain smart sections within notes, as well as limiting the use of AI scribes for certain trainee levels, for example. And so I think those are some of the kind of guardrails that folks are trying to place to ensure that trainees are getting exposed to this technology that's sort of revolutionizing clinical care, while also ensuring that we're preserving the opportunity for them to build clinical reasoning. And we're actually seeing some differences between residency programs and fellowship programs, as you can imagine, just given the level of training between those two populations. But I don't know what the right answer is. I would say that I'm optimistically cautious when it comes to it. I think it's an amazing tool that should be exposed to trainees during training, probably at after the first year or so is probably what I would say. But I think, a lot of the studies that we're doing right now are not going to really yield much insight until kind of further down the line. So it's really hard to say what those implications are going to have on the future of our trainees.
I think that's a good point. This is an area ripe for investigation, and the main issue is that often you don't know that someone didn't get exposure, didn't get capacity until further down the line in their training or in their career, where they missed out on something, and then an incident comes up where they're not able to manage that. And so I think what we've talked about, to Bethel's point, is really thinking critically about when they are, and then using it as an opportunity, as a teaching tool. So, you are generating a transcript right away. And so can the teaching attending use that as an opportunity to see what the resident or the trainee talked to the patient about, how they ask certain questions, et cetera, and give feedback. And so there's really an opportunity to then use this tool to give more real-time feedback, and the note's going to be generated much quicker. And so then it's another opportunity for them to give that feedback. If they're waiting for a day or two for a note to come back, they may not get that opportunity to give them in-person feedback. So there are both opportunities and concerns, and definitely right now at Stanford, we are allowing all of our pediatric residents to use this tool, but with the caveat that it's right now only in our outpatient practices. We have not yet turned it on in the inpatient setting, so there's minimal exposure. There's also, they work at other institutions that don't yet have ambient scribes, and so they'll still have opportunities to practice those skills. But if it becomes an issue where all clinics and all inpatient settings use it, do we need them to have some training wheels first before we turn it on?
Mm-hmm. Yeah, and one small anecdote I'll add to that is we have AI education classes for the med students, and we did an informal survey at the beginning, seeing what people's opinions are on using ambient scribes in practice. And these are first year med students, and many of them actually said that, hey, we shouldn't actually be allowed to use these until later on in training. So I think it's not only like a top-down approach. I think it's the learners as well have an element of wanting to learn how to do this by hand first, which I think is important to know. And obviously it's not a representative sample, but it was an eye-opening stat when we polled the audience.
Okay, we have another question. What have you seen about the quality of the generated note? But anybody wants to answer that?
I can just share kind of some anecdotal experiences of it, and feel free for others to jump in. But I think in my experience of using it for about 100 or so patients, I found that the notes are pretty good about 80 to 90% of the time. I've noticed minor errors, but then I have noticed some. I'll point out one significant error that I noticed. I had diagnosed a child with Lyme disease, and then was describing the antibiotic used to treat it. And we got into a conversation about the potential complications of the condition if left untreated, or what could happen. And the scribe, when it wrote out the note, it actually described the complications of the disease that we talked about. It attributed to the medication. It says the medication can cause all these side effects, and describe the side effects as the complication of the condition. And so I think scribe, and I've noticed that happen a few times in kind of a similar issue with a few other settings. So that's been some of the more kind of extreme examples of errors that I've seen in my use of Scribe so far. And I think there are some folks who are working on trying to do a better taxonomy of classification of errors that come up with these types of tools. I know Dr. Stephen Ma, who's on the adult side at Stanford Healthcare, has recently led a paper doing a taxonomy of classifying the errors that you see in not necessarily ambient documentation, but in AI-assisted messaging. And I think there's more work going on in this space. But overall, I think for my own workflow, using the scribes has been extremely helpful at being able to help me finish notes on time and really capture a lot of the key details.
Great. Well, we're getting close to 1 o'clock, so I wanted to make sure we ended on time. There's a QR code up here if you want to fill out a form to stay in touch with us. Our email, we also have a group email, pedsdigitalhealth@stanford.edu. Feel free to send a message to that or to any of us individually. We're happy to answer any questions. We really appreciate you guys joining us today. And like I said, we'll try and post this recording at some point in the near future as well. So thanks again, and hope you have a wonderful day.